Hello guys, myself is Dr. Abhishek, one of a mentor from Study MRCS. This is about an YouTube series regarding about important topics which is be covered. In this session, we are going to talk about the hepatobiliary surgery, which is important topic which is covered in MRCS Part A. So let's discuss about some of the benign liver lesions. So the first one will be an hemangioma, which is the most common benign tumor of a mesenchymal origin. So one of the MCQs which can be expected is the most common benign liver lesion will be a hemangioma. Among them, the cavernous hemangioma is the most common. There are two types, capillary and cavernous hemangioma, whereas the cavernous hemangioma is the most common one. This on an gross, it appears as a reddish purple hypervascular lesion. Most of the time, it will be incidental loma, which is about less than 5 centimeter in the nature. So if it is more than that, and if it is causing any vascular lesions or mass producing lesions, in such conditions, we have to go for an the surgical section. So the diagnosis will be of an on an ultrasound as an incidental finding, which will be of typically hyperechoic in nature, and the serum AFP levels will be normal. That's how we're going to differentiate from the other mass benign liver lesions from hemangioma. Coming to the liver cell adenoma, this is also one of the common benign liver lesion, which is of pre-malignant in nature, but it's a benign in one. So this most of the time occurs in the women's. The typical feature what we seen is the use of oral contraceptive pills. Okay, so the liver cell adenoma will be associated with the usage of an OCPs in the females. The lesions are usually solitary in nature and they're sharply demarcated from normal liver, although they lack an fibrous capsule. On an ultrasound examination, they show a mixed echocity and heterogeneous texture. Okay, CT scan lesions will be hypodense in nature, and patients with any of this symptomatic in nature, like hemorrhage, mass occupying lesions, in such conditions, will go for a surgical resection. Liver abscess is one of and the infective pathology of the liver with benign mass. So the liver biliary sepsis is a major predisposing factor for the development, and also any infection from other drainage by the portal venous system will also act as an and the source. So the patient usually presents with a fever, right upper quadrant pain, and jaundice. On ultrasound examination, you will feel the fluid-filled hyperechoic lesions with the multiple whenever there is an chronic abscesses, we can see the hyperechoic walls like a septase. Amoebic abscess is one of the form of a liver abscess, and it's one of the most common extraintestinal manifestation of an amoebiasis. And this usually occurs in patient presents with the toughen and the fever and the right upper quadrant pain. Most of the time, it will present the right lobe of the liver. On an ultrasonography, the usually it shows a fluid-filled structure with a poorly defined boundaries, and the aspiration of this lesion will yield some characteristic Hankovi paste consistency, a sterile odorless fluid. That's a typical clue that gives us for the diagnosis of amoebic abscess. Okay, the given scenario of an amoebiasis with intestinal manifestations. Along with, they also say that the on an aspiration of the mass, which gives an Hankovi paste consistency or anchovy mass appearances on and the aspiration, then the diagnosis will be goes in favor of amoebic abscess. Most of the time, it will regress by itself by an surgeon, by an medical line of management, where we going to treat with a metronidazole. Hydatitis is also one of an the infective pathology which produces a benign liver lesion, and this is caused by an the tapeworm parasite called as Echinococcus granulosus. Okay, and when you this is usually an intense fibrotic reactions usually occurs around the site of an infection. They don't have any epithelial lining, and they are usually unilocular in nature. They ranges with the various sizes. They can grow up to 20 centimeter in the size. Okay, so this unilocular cyst which lacks an epithelial lining has a thick cell wall. Okay, and they contains an the fluid which is highly allergic in nature. Okay, cystic fluid which are highly allergic in nature. Once the body exposed to this cystic fluid, the patient will develop an type 1 hypersensitivity reactions. The patient with the hydatitis usually presents the triad of biliary colic, pain, jaundice, and urticaria will be there. Okay, CT is the best investigation choice to identify an hydatid cyst, and treatment usually involves first with the sterilization of the cyst. We'll make it as a non-infective and non-allergic by giving with a mebendazole initially, followed by which you're going to go for the surgical resection. This is a picture of the multiple hydatid cyst inside the liver. Polycystic liver disease, this usually associated with a lot of other cystic diseases like polycystic kidney diseases. It's also associated with some of the berry aneurysms in the brain. Okay, it's an autosomal dominant inherited disorder, ADPKD gene in a mutant. And symptoms usually occurs as a result of capsular stage. Patient will have a dull-lacking type of pain, and sometimes if it's multiple and if it is and the larger in nature, that it causes a mass effect. Cystadenoma is also one of a rare benign liver lesion with a malignant potential. They also usually there will be a solitary but multiloculated lesions. The liver test function tests are usually normal in nature. When you do an ultrasound, you can see the large anechoic fluid-filled area with irregular margins and internal echoes due to an sepsis. Surgical dissection is indicated in all of the cases of cystadenoma as it's a pre-malignant in nature. Coming to the biliary diseases, before jumping into one biliary disease, let's understand regarding about a few points about bilirubin metabolism. So from the sensates RBCs, so from the spleen, so once the hemoglobin is released from an RBC, the heme and the heme undergoes an metabolism by the action of heme oxygenase to form biliverdin. Biliverdin, by the action of biliverdin reductase, it forms an unconjugated bilirubin. So this unconjugated bilirubin will be carried out at bound to an albumin and carried to the liver for the conjugation. Once it enters into the liver, by the action of UDP glucuronide transferase enzyme inside the liver, it converted into conjugated bilirubin. So this conjugated bilirubin via the biliary secretions, it enters into the intestine, where by the action of the gut flora, it will be reduces to form a steatobilinogen and probilinogen. So this again, the unconjugated bilirubin level enters into enterohepatic circulation, where the part of it will be excreted in the kidney, and again the other remaining 94% of will be entered into one again to one a liver to get a conjugations. Whereas the remaining part of an the steatobilinogen will be excreted in the feces to give an fecal color. So we divide based upon the regarding about the surgical jaundice, we divide them into pre-hepatic, hepatic, and the post-hepatic regarding about and the based upon the site of pathology of involvement. Okay, so here the pre-hepatic is nothing but before the conjugation occurs. So the patients who have a pre-hepatic jaundice will have an increase in unconjugated bilirubin level because they have a pathology which causing an obstruction of the unconjugated bilirubin entering into the liver. So in an hepatic jaundice, the problem with the liver itself, so the patient will have a mixed type, both unconjugated and the conjugated. It depends upon the which part of the pathology has been involved. Next, coming to the post-hepatic jaundice, once the conjugated bilirubin has been formed from the liver, it will fail to excrete within the into an intestine. That's called post-hepatic jaundice. Most of the time it will be obstructive in nature, and here the patient have an increase in conjugated bilirubin level. So it's called a conjugated hyperbilirubinemia will be present. Coming to the causes of it, we divide the pre-hepatic, it be because of an and the increased hemolysis. So there is excessive production of the heme, which responsible for an increased production of an bilirubin. Okay, so this can be of an hemolytic mediated or non-hemolytic, non-immune mediated hemolysis reactions of the RBCs. Sometimes there are just some of the genetic disorders like Crigler-Najjar syndrome can also be involved. Then certain hepatic disorders starting from hepatitis to the cirrhosis to an and the carcinomas, the patient usually end up with having an hepatic jaundice. Then with the post-hepatic disorders, where a patient causes an obstruction to the top and the secretion of bilirubin, conjugate bilirubin into an and the intestine. So this can be start from any of the mass lesions in and around and the like pancreas, cholecystitis, cholelithiasis, or any duodenal masses can end up with this. So for the diagnosis of surgical jaundice, we divide based upon the pre-hepatic, hepatic, and post-hepatic. We look after these levels, that is bilirubin, ALT, AST, and alkaline phosphatase level. So based on these three levels, we can differentiate whether the patient having pre-hepatic, hepatic, or the post-hepatic. In case of the pre-hepatic jaundice, patient the bilirubin level will be maybe a normal or the high. But most of the time, the whole other liver para enzymes like ALT and AST, and even the alkaline phosphatase will be normal in nature. Whereas in hepatic, where the liver is involved, the liver enzymes like ALT and AST will be elevated, and bilirubin is also will be elevated, but alkaline phosphatase will be normal. In post-hepatic, the alkaline phosphatase level will be increased, ALT, AST will be moderately raised, whereas bilirubin is also highly raised. So in case of pre-hepatic, all the levels appears to be a normal, only the bilirubin level will be elevated. Whereas in hepatic, it's a liver enzymes where ALT, AST will be elevated. In post-hepatic, it's alkaline phosphatase which is elevated, along with some of the clinical features in posthepatic like passage of an and the pale color stools due to the absence of stechobilinogen and if the presence of yellow colored urine. So this always gives an idea regarding about and the posthepatic jaundice in a clinical scenario. Coming to some of the causes for jaundice, most of them will start with the cholelithiasis, that's called gallstones. Typically, patient usually presents the biliary colic with episodes of cholecystitis. So the obstructive type of history, as I said, they will be having an and the pale colored stools with yellow colored urine and jaundice will be present, and the test results also where the increase in the alkaline phosphatase level will be present. So on and the most common cause of these gallstones will be the cholesterol stones, usually which causes this, and pathogenesis is usually the small caliber gallstones which can pass through a cystic duct. This Macy syndrome is nothing but it's a condition where the stone will be lodged into a cystic duct, but it's causing an obstruction to the common hepatic duct. So that will be obstructive type of jaundice by a gallstone which is present in the cystic duct. That's called Mersey syndrome. Comes the bile duct directly. One of the rare types of cholecystitis may present with the jaundice. Cholangitis, it is nothing but it's an infection of a biliary tree. Okay, so that's called as an cholangitis. It's also causes an obstructive type of an jaundice. Patient usually have a Charcot stripe, that is a symptoms of upper quadrant pain, and the patient will have an high grade of the fever, and they'll have an jaundice manifestations. If it is a very severe cholangitis, patient will have a Reynolds pentad. Along with the pain, fever, and the jaundice, patient will have an altered mental status and patient will have an hypotension. That's called a Reynolds pentad. Pathogenesis, there will be an ascending infection of the bile ducts. Usually it is caused by E. coli infections and some defining in a poor definition occurring in the pool of stagnant bile. So that's why patient will have the jaundice in cholangitis. Biliary duct injury, this depends upon the type of injury, which usually most of the time it will be iatrogenic in nature. And this will be of sudden and the gradual, or it may be a gradual onset of obstructive type of jaundice again. So it's this most of the time occurs in case of laparoscopic cholecystectomy, where when the pathology of an and the callus triangle has been altered and you can't able to exactly delineate the structures in such conditions, patient may end up with a bile duct injury immediately post-operatively. Then you have to suspect this. Specific gallstones and gallbladder related disorders. Biliary colic, we already read. Patient will have a colic abdominal pain, which was postprandially, those with after the heavy fatty meal. Okay, but why? Because that will stimulate the release of and the bile from the gallbladder. The management usually involves shows imaging showing in gallstones, which is by USG. With ST compatible, then laparoscopic cholecystectomy can be done. Depends whether it depends upon the cholecystitis too. Then we have a cholecystitis. It may be acute or the chronic one. So that's nothing but inflammation of the gallbladder. Okay, so patient will have an right upper quadrant pain of an abdomen, and patient also complain of a fever with the jaundice, and there will be Murphy sign on examination. That is nothing but the tenderness along the tip of the ninth costal cartilage on a deep inspiration. Okay, so that's what the tenderness present. That's a Murphy sign. This is due to an inflamed gallbladder touching your tip of the finger, and occasionally there may be deranged lefty too. Management usually imaging with an ultrasound with a CT scan diagnosing it. Ideally, have to go with the surgery. Subtotal cholecystectomy may be needed if a scalene triangle is hostile. Sometimes, in case of an unfit patient, you go with a percutaneous aspiration drainage. Gallbladder abscess, this is also often condition where usually patient will have a prodromal illness with the right upper quadrant pain. Since it's an abscess, there will be continuous swinging pyrexia will be present. Sometimes patient will be systematically unwell. They may be develop a sepsis too eventually. Generalized peritonitis may not present in gallbladder abscess. Once it becomes a complicated rupture into the peritoneum, then the peritoneal features will be present. Management of again diagnosis by imaging technique by USG with or without requiring a CT scan, and surgery will be an excision. Cholangitis, we already read regarding about this. Management includes a fluid restriction, broad spectrum intravenous antibiotics for the prolonged duration of the time, and early as it will be helpful for us. Coming to the gallstone ileus. Gallstone ileus is nothing but whenever there is an and the gallstones, I mean the cholesterol stones which is formed, it will entering into one and the this is intestine and causes an and the small bowel obstruction. That's called gallstone ileus. This occurs whenever there is an abnormal communication between the common bile duct with the top and the duodenum. In such conditions, the stones may escape and that may cause the obstruction to the small bowel. Patient usually have an history of a previous cholecystitis and the gallstones. Okay. Management in this laparotomy and removal of the gallstones from the small bowel. The enterotomy must be made proximal to the site of an obstruction and not at the site of obstruction. That's again an important MCQ. The fistula between the gallbladder and the duodenum should not be interfered with. A calculus cholecystitis, here the patient will have all the features of a cholecystitis, but the absence of the gallbladder. That's what in a calculus one, and they have an intercurrent illnesses. Patient will have predisposing events like diabetes, organ failures, systemically unwell. So these are some of the predisposing factors which make a gallbladder to get inflamed. Management usually with if a patient is fit, we go for an cholecystectomy. So one of an MCQ, a 43-year-old man with a long-standing chronic hepatitis is being followed up. His recently AFP values noted to be increased. An abdominal ultrasound demonstrate and 2 centimeter lesion in the segment V of the fifth of the liver. What is the important or most appropriate course of an action? So either PET CT scan, liver MRI, investigate liver biopsy, laparoscopic biopsy, a segmental section of an and the fifth involved segment. So here what we have to look for, patient has a chronic long-standing hepatitis and his AFP levels are noted to be increased. The ultrasound demonstrated 2 centimeter lesion. So hepatitis with a background with the AFP being a marker of an the carcinoma. So patient is found to be have developed an hepatocellular carcinoma secondary to a long-standing chronic hepatitis. So in these conditions, what is the most appropriate course of an action? What we have to do? In such conditions, we have to go for a liver MRI. Okay, here the liver MRI, because once you suspect the presence of an hepatocellular carcinoma, we have to look whether it is a focal lesion or the multifocal lesion. What is the amount of a spread? Okay, or what is how we want to manage it? So that's all requires and for the management. So we require a liver MRI. So that's the most appropriate investigation in this. So in detail about hepatocellular carcinoma, so it's the second leading cause of cancer death globally. And this most commonly occurs following in chronic hepatitis, either secondary to a viral hepatitis or secondary to an alcoholic hepatitis or some of the other causes of hepatitis. Eventually, patient will land up in cirrhosis, and cirrhosis will automatically leads to a carcinoma. And the enzymes AFP level will be elevated. USG will be done in order to as an initial line of management. Okay. And suspect the hepatocellular carcinoma whenever the ultrasound found to be and more than 1 centimeter of the solitary lesions or the multiple lesions with an raised AFP levels. Okay, so that with the risk factors like chronic hepatitis or viral hepatitis, in such conditions you have to think in terms of hepatocellular carcinoma, and we have to evaluate eventual. So diagnosis usually CT scan on the classical feature suspicious lesion highlighted during the arterial phase, which are washed out during the venous phase. This reflects the hypervascularity of the lesion. So that diagnosis have to suspect it. Okay. Then we have something called Barcelona Clinic Liver Classification. This is a convenience of categorizing the disease extent with the treatment and prognostic outcomes. Okay. So determining what is the ideal treatment modality for it based upon the functional state of a patient and as well as in the liver. So that we have an 5-grade stage 0, where a single lesion of less than 2 centimeters. In such conditions, you can go for the resection, okay, direct resection of the entire segment involved. Stage A, where the single nodule will be more than 3 centimeters or the multiple small nodules, which is less than 3 centimeters. In such conditions, if it is an associate with another diseases, go for the radio frequency ablation. If there is no any associated lesions along with that, go for a liver transplantation. Stage B, like multiple nodules, they have to do one transarterial chemoembolization, usually with the doxorubicin, what we do. Stage C, where it's advanced tumor with invasion of the portal veins. There's a newer drug with a tyrosine kinase inhibitor, that is sorafenib, can be used, which found to be effective in nature. Then the stage T with advanced tumor with the extensive metastasis. In such conditions, always go for the palliative care of treatment. Sorafenib is basically it's an oral multi-tyrosine kinase inhibitor. This found to be very effective in case of treatment of hepatocellular carcinoma. Coming to some of the recalls, a 68-year-old man with a type 2 diabetes is admitted to the hospital and being unwell. On an examination, he has a features of septic shock and right upper quadrant tenderness. He is not jaundiced. Imaging shows a normal caliber bile duct and no stones in the gallbladder. What's the most likely diagnosis? So what we have to suspect here, one major striking feature will be a no stones. and the normal caliber bile duct. So there will be no stricture, no adhesions, and there is no stones too. But the gallbladder is very inflamed, and there is also no jaundice. But he has a features of septic shock with a right upper quadrant tenderness. So there should be certain infectious type of inflammation which is occurring. So there will be it directly goes with the favor of acute acalculous cholecystitis. Okay. So, and with the since the patient is already having an endoseptic shock underlying with the type 2 diabetes, so we think in terms of acalculous cholecystitis. When a 43-year-old lady presents with a 24-hour history of a generalized right upper quadrant pain, on an admission, she is a septic and jaundiced, and there is a tenderness in the right upper quadrant. What's the most likely diagnosis? So here, patient has an tenderness too, and he has also jaundice, and she is in septic shock. Okay, so the answer directly goes with the favor of cholangitis. Sepsis favors the diagnosis of cholangitis. All the triad features will be present. A 23-year-old lady presented with a right upper quadrant pain. On examination, is tender in the right upper quadrant. Imaging shows signs of acute cholecystitis due to a gallstones. The CBD appears normal. The liver function tests are normal. What's the most appropriate course of an action? So whenever there is an acute cholecystitis, we have to go for the cystectomy. So since it is an and there is no any adhesions or there is no any abnormalities, you can go for the laparoscopic cholecystectomy during the next 24 to 48 hours. An 82-year-old lady is taken to a theatre for the common bile duct exploration. She hasn't stone impacted the distal aspect of common bile duct. And despite the best efforts, it proves it's impossible to remove it. What's the best course of an action? So there is a diagnosing of a gallstone which is present in the common bile duct. Okay. So now with surgery itself, it's unable to remove. So what is the next course of an action you're going to do? Either you're going to close a bile duct over a T-tube and arrange for the stent to be placed, undertaken choledochoduodenostomy, arrange for an repeat ERCP, construct an hepatojejunostomy, bypass the gallbladder onto the jejunum. Among this T-tube arrangement of stent to be placed again by surgically, it's impossible. Arranging for repeat ERCP when surgery itself is placed, failed, going for ERCP again, it's not a good idea. So constructing an hepatojejunostomy is also a good, but it's better if you take an choledochoduodenostomy, connecting and the gallbladder to the tough and second part of the duodenum, where there will be a second or third part of the duodenum, where that how you are going to drain the stones from it. Okay, so that's one thing. In this cases, again, the bypassing the distal bile duct and choledochoduodenostomy is the best way to achieving this. But there is a long-term risk of cholangitis because the intestine itself is directly connected to the tough and the gallbladder. So, but here it's a less of concern because it's a more concern about on the gallstone, which is getting obstructed CBD duct. So that's being about the end of this YouTube series. We are mainly concentrated upon the important topics which will be asked in the MRCS Part A. Okay, thank you.